You wake up and your hand is gone. Not painful, just gone. A dead weight at the end of your arm buzzing like static electricity through every finger. You shake it, you squeeze it, slowly feeling creeps back, and you tell yourself, that is just how I slept. Maybe you have been telling yourself that for 6 months, maybe 2 years, and every morning you shake that hand awake and find a reason it makes sense. The pillow, the mattress, the way you rolled over. I want to talk about what your body is actually saying, because the explanation you have been giving yourself is almost certainly incomplete, and in some cases it is missing something that has been quietly worsening the whole time you have been asleep. Before anything else, what I share here is educational information only, not medical advice. Please always work with your own doctor before making any changes to your health routine. What I want to give you today is the knowledge to walk into that conversation with far better questions than you currently have. Stay through the entire video, because number one on this list is the piece that connects everything else, and the piece most adults never hear from a routine appointment. I am Dr. Andrew Carter, 15 years working exclusively with adults over 60. I have heard this complaint hundreds of times, the numb hand in the morning, dismissed, explained away, accepted, and I have watched people spend years living with a symptom that had a name, a cause, and a solution, but nobody who took the time to find it. What I am about to share is not radical. It is what the research says, clearly and consistently. The problem is that most of it never makes it into a standard appointment, and I am tired of that gap. If you are new here and you want real explanations for what is happening inside your body after 60, not guesses, not generalities, subscribe right now. Every week I come here with one purpose: to give you information that actually makes a difference. Your hands go numb because something is interrupting the nerve signals that keep them feeling alive. The complicated part is where that interference originates. The nerves supplying your hands start in the cervical spine, the vertebrae in your neck, then travel through a network called the brachial plexus across the chest under the collarbone, down the arm, around the elbow, through the wrist, and into every finger. Every section of that journey is a potential problem site, and problems in completely different locations can feel identical from the outside. Neck compression and wrist compression both cause tingling in the hand. Thyroid disease and diabetes both produce numbness in the fingers. This is why my hands go numb at night. Tells you almost nothing useful on its own. What matters is which fingers, which hand, or both, how long before it clears, whether neck or shoulder discomfort accompanies it, and whether it is getting worse over time. A paper published in the British Medical Journal found that when patients described their symptoms with this level of precision, diagnostic accuracy on first evaluation more than doubled. Not better doctors, better information going in. As I go through each cause, notice which one matches your experience and type that number in the comments. Number 10, the case where sleeping position really is the cause, but is being amplified by something deeper. Sleeping with a folded wrist or a compressed arm can genuinely cut off nerve conduction and wake you up. In a person with a completely healthy nervous system, it resolves in under 2 minutes and rarely happens twice in the same night. In adults whose nerves are already operating with less reserve from declining B12, from any degree of disc narrowing, from early metabolic changes, the threshold is dramatically lower. The same position that caused zero trouble 10 years ago now creates significant symptoms after 90 minutes. Not because the position changed, because the nerves underneath it changed. A study in the journal Sleep Medicine found that positional hand numbness lasting more than 5 minutes after repositioning was a reliable indicator that something structural or systemic was amplifying the response. 5 minutes is the line. Under 5, likely positional. Over 5, something else is involved. Try sleeping with arms resting loosely rather than folded. A nighttime wrist brace holds the joint in a neutral position and prevents tunnel narrowing during sleep. If wearing one eliminates the numbness, the wrist is the primary site. If it makes no difference at all, the problem is originating somewhere further up that nerve road. Number 9, the elbow problem that gets blamed on the wrist almost every single time. The ulnar nerve wraps around the inside of the elbow through a channel called the cubital tunnel, then runs down the forearm into the ring finger and the pinky. When that channel narrows from bone changes, inflammation, or the sustained pressure of sleeping with the elbow sharply bent, the nerve gets compressed. The result is tingling and numbness in those outer 2 fingers specifically, not the thumb or index finger, the outer 2. That distinction is one of the clearest diagnostic clues in upper extremity neurology. Carpal tunnel affects the thumb, index, and middle finger. Cubital tunnel affects the ring finger and pinky. 2 completely different nerves, 2 different sites, 2 completely different solutions. The Journal of Hand Surgery has documented that cubital tunnel syndrome is the second most common nerve entrapment in the arm. Yet in older adults, it is routinely misidentified because most evaluations never ask which specific fingers are involved. If it is your outer fingers, your elbow is likely the source. An elbow pad preventing full bending during sleep can produce striking improvement within days at virtually no cost. Number 8, The nutrient deficiency that does not directly cause this problem but makes every other cause dramatically worse. Vitamin B12 does not compress the carpal tunnel or push on a disc in the neck. What it does is determine how well the nerve inside those structures tolerates any challenge. Every nerve is wrapped in myelin, a layered sheath that insulates the fiber and keeps signals traveling at the right speed. Myelin is constantly degrading and needs B12 to rebuild. When B12 is genuinely available at the cellular level, that maintenance runs on schedule. When it is not, because the form being taken is not absorbed or the pathway has been blocked by age or medication, myelin thins. A thin sheath is less insulated, more reactive to pressure, and far less tolerant of any positional stress during sleep. Picture two people with identical carpal tunnel narrowing. One has healthy myelin and sleeps through the night. The other has myelin that has been slowly degrading for 2 years and wakes up numb after 90 minutes. Same anatomy, completely different outcome. The B12 status is the variable. The Annals of Neurology published data showing exactly this. Adults over 60 with suboptimal cellular B12 reporting substantially higher rates of morning nerve symptoms, even when structural findings in the wrist and neck were equivalent to those with no symptoms at all. Cellular is the key word. Standard serum B12 does not tell you what is reaching the nerve. Methylmalonic acid and homocysteine do. Elevated MMA means the cell cannot complete its normal reactions. Elevated homocysteine means the conversion pathway protecting nerve tissue is running inefficiently. Most adults have never had either test run. Type the number 8 in the comments right now if your doctor has tested your serum B12 but never once mentioned methylmalonic acid or homocysteine. That testing gap is far more common than it should be. And if this is your first time here, subscribe and ring the bell. This is the kind of information I bring every single week. I want to tell you about Margaret, 72 years old, retired nurse from Boston, Massachusetts. 15 months of waking up with both hands numb. Mentioned it at 2 appointments, told it was likely positional both times. No further investigation. Her serum B12 was 298, technically in range. TSH at 3.9, also within range but sitting at the upper end. Nothing flagged, nothing pursued. When I ran methylmalonic acid and homocysteine, both came back elevated. Her cellular B12 was genuinely inadequate despite that normal-looking serum number. Her thyroid was adding soft tissue swelling at the wrist, and years of sleeping on her side had chronically irritated her ulnar nerve at the elbow. 3 contributors, each one mild, together more than enough to wake her every single morning for over a year. We started sublingual methylcobalamin, had a conversation with her physician about the thyroid picture, and changed her sleep position. 6 weeks later, she called me. First night sleeping through without waking up numb in over a year. She said, I assumed I was just getting older. I told her that was the one explanation nobody ever actually tested. Number 7. The blood sugar connection most people do not realize reaches all the way to their fingertips. When blood glucose stays elevated over time from diagnosed diabetes or the quieter state of prediabetes that often goes unaddressed for years, the small blood vessels nourishing peripheral nerves begin to deteriorate. They narrow. The nerve they supply starts receiving less oxygen and fewer nutrients. It loses function from the outside in. This is peripheral neuropathy. Half of all adults with type 2 diabetes will develop it to some degree, and in about a third of those cases, the hands become involved. The pattern is often described as wearing an invisible glove, a muted, slightly absent quality to sensation, sometimes a faint tingling that never fully resolves. And because the nerve is already metabolically compromised, even minor positional pressure during sleep that a healthy nerve would completely ignore becomes enough to disrupt the night. Data from Diabetes Care confirm that frequency and severity of nighttime symptoms track closely with average glucose control over the preceding months. Better control, fewer disruptions. No brace, pillow, or supplement addresses glucose-driven nerve erosion. If your fasting glucose has been above a 100 for more than a year, that is not a separate issue from your hands. It is the same issue. Number 6, the thyroid connection and why it produces carpal tunnel in people who have never done a day of repetitive wrist work. When the thyroid is underactive, hypothyroidism, considerably more common after 60 and more prevalent in women, one consequence is the accumulation of a substance called mucin in connective tissue. Mucin draws water in, tissue swells, and when that swelling happens in the confined carpal tunnel at the wrist, the median nerve has nowhere to go, not from overuse, not from anatomy, from a hormone. This behaves differently from mechanical carpal tunnel. Symptoms typically affect both wrists. They do not worsen with specific hand activities. And they do not respond to splinting because the pressure is coming from inside the tissue itself, not from the angle of the joint. The Journal of Clinical Endocrinology and Metabolism documented this clearly. When thyroid hormone is adequately supported in hypothyroid patients with carpal tunnel, symptoms frequently reduce substantially without any direct intervention at the wrist. TSH within the reference range does not rule this out. The range is wide. Ask for free T3 and free T4 alongside TSH. Those numbers reflect what is actually circulating in the tissue. That is where the real story is. Number 5, carpal tunnel syndrome, understood properly, not the way most people have been told about it. The carpal tunnel is a narrow bony passage at the base of the palm through which the median nerve and 9 tendons travel. Very little space to spare. When anything increases pressure inside that channel, inflammation, fluid retention, arthritis, or the swelling from thyroid dysfunction, the median nerve has nowhere to go. Night makes it worse because the wrist naturally curls inward during sleep, tightening the passage further. After a few hours of sustained compression, the nerve wakes you. Research published in Muscle and Nerve found an average diagnostic delay of over 2 years in adults over 60 because symptoms get attributed to arthritis, aging, and circulation before anyone considers nerve compression. It is also overtreated surgically. Nighttime neutral splinting is first-line care for a reason. It works for a significant number of people without any cutting. Anti-inflammatory measures come next, injections after that. Surgery is for cases where everything else has been tried. That order matters, and it is frequently skipped. I want to tell you about Charles. 69, retired firefighter from Phoenix, Arizona. 4 decades of physical work, bilateral hand numbness, first 3 fingers every night. His doctor recommended surgery. Charles came to me before agreeing to it. TSH at 4.8, free T4 at the bottom of the reference range, unexplained weight gain over 2 years, cold in rooms others found comfortable, fatigue that did not match his otherwise active life. He had mentioned all of it at appointments, told each time his labs were fine. We brought those findings to his physician with a specific request. Take a closer look at the thyroid picture. 3 months of appropriate thyroid support later, his nighttime hand symptoms had dropped by approximately 70%. No surgery, no injections, no bracing. His surgeon, when told the outcome, said, "I genuinely would not have thought to look there." I told Charles that gap is exactly what this video exists to close. Number 4, a compression most doctors never mention and most patients never suspect. Between the collarbone and the first rib sits a narrow corridor called the thoracic outlet. Through it past the brachial plexus nerve bundle, the artery supplying the arm and the vein returning from it. If that space narrows from decades of forward head posture, tight chest and shoulder muscles, or structural bone variants, all 3 can be affected simultaneously. The symptoms are aching in the shoulder running down the arm, numbness throughout the hand rather than in specific fingers, and heaviness when reaching overhead or carrying weight. Often worst in the morning after hours in a position that altered the shoulder geometry during sleep. Standard tests miss it entirely. A wrist nerve conduction study will be normal. A neck scan will show nothing significant. Without those positive findings, the conclusion is often nothing is wrong. The Annals of Thoracic Surgery documented an average delay of 18 months before correct identification, during which patients receive wrist braces and reassurances that do nothing. If your numbness involves the whole hand rather than specific fingers, if the whole arm aches, and if carrying a bag consistently makes things worse, raise thoracic outlet syndrome directly with a neurologist who evaluates it specifically. Number 3, the neck, where the trouble for your hand often begins long before it ever reaches the wrist. Between each cervical vertebra, nerve roots exit through openings called foramina. In a spine carrying a 10 to 12 pound head for 6 decades, those openings are narrower. Discs have flattened, bone spurs have formed along the vertebral edges. The nerve root that once exited freely now navigates a passage half its original size. When that root is compressed, the signal it carries is disrupted, and the area it supplies reports it. Compression at the 6th cervical level affects the thumb and index finger. The 7th cervical level routes to the middle finger. The 8th and 1st thoracic levels affect the ring and little finger. Consistent, predictable mapping. If you know which finger is most affected, you have a reasonable inference about where in the neck the problem lives. This worsens at night because the head stays in one position for hours, continuously loading the narrowed opening. A cervical support pillow that cradles the neck's natural curve rather than pushing the head forward can reduce that nightly load enough to make a noticeable difference within 1 to 2 weeks. A study published in Spine confirmed that cervical radiculopathy peaks in incidence in the decades around 60, making it one of the most common neurological presentations in this age group. Number 2, the symptoms that mean this conversation ends and a phone call to your doctor begins today. Most causes here develop gradually and allow time for careful evaluation, but some presentations are a completely different category. If your numbness came on suddenly, not building over weeks but appearing one night with no prior history, that requires urgent evaluation. Sudden neurological onset is not the same as morning hand numbness. If weakness has developed alongside the tingling, dropping objects, unreliable grip, difficulty with jars, that is a motor finding on top of a sensory one, signaling a more significant degree of nerve compromise. If numbness has moved to the face, tongue, or trunk even briefly, call your doctor the same day. If speech, vision, or coordination has changed alongside the hand symptoms, even for a few minutes, treat it as a medical emergency. Do not wait. If your handwriting has progressively worsened, if small buttons are harder, if precision tasks feel less controlled, progressive fine motor deterioration can signal spinal cord involvement. That is a neurological urgency requiring immediate evaluation. A study published in JAMA Neurology found that even one of these additional features dramatically raised the likelihood of a serious, time-sensitive underlying cause in adults over 60 with hand numbness. Type yes in the comments right now if any of these apply to you and you have not yet spoken to a doctor about them. Please do not let that sit. And if this video has opened something for you, share it with one person waking up with numb hands and writing it off. You might be handing them an answer they have been waiting years for. Subscribe if you have not yet. Every week I come here with exactly this kind of information. Number 1, the reason most people's answer is incomplete and why treating a single cause while the others remain almost always falls short. Think of your nervous system as a bridge. When it is new, it handles enormous load without complaint. Over time, without the maintenance it needs, small things accumulate. A stress fracture here, corrosion there, the load capacity quietly drops. Then one day an ordinary delivery truck crosses and something gives, not because the truck is exceptional, but because the bridge can no longer absorb what it once barely noticed. That is what happens to a nervous system losing support in multiple areas at once. B12 absorption impaired by declining stomach acid and years of medication. Cervical discs narrowed from 6 decades of gravity. Carpal passage gradually tightening, thyroid function at the lower edge of normal. Fasting glucose slowly climbing into the prediabetic range. Each change is small, none triggers symptoms alone, but the total demand on that nerve across the entire distance from neck to fingertip has been building for years, and one night a slightly bent wrist is the one thing too many. You wake up numb. This is why single-cause treatment produces partial results at best. The splint helps a little, the supplement shifts a little, nothing resolves fully, and the person concludes this must simply be what aging feels like, and stops asking. A study in the journal Aging and Disease found that in over 70% of adults over 65 with peripheral nerve symptoms, 2 or more distinct contributing factors were simultaneously present: nutritional, structural, metabolic, and postural, all interacting, all loading the system. Yet most clinical evaluations document the most obvious one and proceed from there. The approach that works reduces the total burden from every direction at once. B12 confirmed at the cellular level with the right tests. Thyroid evaluated beyond a single TSH. Blood glucose trajectory known and actively managed. Neck supported correctly during sleep. Elbow and wrist positioned to reduce nightly nerve pressure. And the patience to give consistent change, several weeks to produce results. I want to tell you about Barbara. 76, retired accountant from Atlanta, Georgia. 2 years, 2 doctors, both diagnosing carpal tunnel. 18 months of nightly wrist bracing. Not a single change. She came to me and said, I am starting to think I just have to accept this. I asked her to describe the symptoms precisely: both hands, first 3 fingers, worst in the 2 hours before waking, mild fatigue, fasting glucose at 108, sitting in her chart for 3 years, never once connected to her hands, TSH at 5.1, free T4 at the floor of the reference range, MMA elevated, homocysteine elevated, a cervical scan she had never had, moderate narrowing at C6, C7 on the right. 4 contributors, each manageable alone, together the reason 18 months of bracing had never touched her symptoms. Sublingual methylcobalamin with methylfolate. Her physician addressed the thyroid and glucose numbers directly. A cervical support pillow. Targeted exercises for the neck and upper thoracic spine. At 6 weeks, 3 consecutive nights without waking up numb. At 3 months, symptoms down to twice a week. At 5 months, she told me she had stopped thinking about her hands entirely. She said, nobody ever put it all together before. I told her that is exactly what needed to happen. Here is what you do starting this week. Write down your symptom picture precisely, which fingers, one side or both, how long to clear, whether neck tightness or shoulder discomfort accompanies it. Bring that written description to your next appointment. This single step doubles diagnostic accuracy. Try nighttime wrist bracing for 2 weeks. Neutral position, not tight. Significant improvement means the wrist is a primary site. No change means the problem is upstream. Ask your doctor for a complete panel: serum B12, methylmalonic acid, homocysteine, TSH with free T3 and free T4, fasting glucose and HbA1c. A serum B12 and TSH alone do not give you the full picture. Adjust your sleeping posture, arms at your sides, not folded under, a cervical pillow maintaining the natural neck curve, a soft elbow pad if your elbow tends to bend sharply during sleep. If you are on a standard cyanocobalamin tablet, consider switching to sublingual methylcobalamin. Hold it under the tongue for 60 seconds. For adults over 60, that delivery difference matters. Positional changes show results within the first 2 weeks. Systemic contributors B12, thyroid, glucose take 4 to 6 weeks for initial improvement and up to 3 months for sustained change. 5 things that slow recovery down. 1. Investigating one cause at a time before looking at others. Multiple causes are almost always operating together in this age group. Look at all of them from the start. 2. Accepting a normal TSH as a complete thyroid verdict. The reference range is wide. Free T3 and free T4 show what is actually circulating in tissue. Ask for them specifically. 3. Abandoning the plan every 2 weeks because nothing seems to be moving yet. Myelin does not rebuild in 10 days. Give any consistent protocol 12 weeks before drawing conclusions. 4. Addressing structural causes while leaving the B12 foundation unbuilt. Wrist splints, cervical pillows, and physical therapy all have a ceiling set by the health of the nerve underneath them. Build the nutritional base first, and every other intervention performs better above it. 5. Carrying any blame for how long this has gone unresolved. You were told it was the way you slept. You were handed a brace. You were told your labs were fine. You did what any reasonable person would do with the information available. Now the information is better. One final pass through everything. Number 10. Positional compression is real, but when it is frequent and prolonged, it signals underlying nerve vulnerability rather than simply a bad sleeping habit. Number 9. Cubital tunnel syndrome affects the ring and little finger, originates at the elbow, and is routinely misidentified because no one thought to ask which specific fingers were involved. Number 8. Cellular B12 insufficiency, confirmed by methylmalonic acid and homocysteine, not serum alone, lowers every nerve's tolerance for any kind of physical or positional stress. Number 7. Diabetes and prediabetes erode the blood supply to peripheral nerves over years, creating a baseline of reduced function that even minor nighttime pressure can overwhelm. Number 6. An underactive thyroid drives tissue swelling inside the carpal tunnel, producing bilateral wrist symptoms that respond to hormone support rather than wrist surgery. Number 5. Carpal tunnel syndrome is real and common, but best approached with conservative measures first, with correction of underlying metabolic contributors long before surgical options enter the picture. Number 4. Thoracic outlet syndrome compresses the entire nerve bundle between the collarbone and the first rib, produces symptoms throughout the whole arm and hand, and is regularly missed for well over a year. Number 3. Cervical radiculopathy sends disrupted signals from compressed neck nerve roots into specific predictable fingers, and it responds to proper cervical support and sleep positioning. Number 2. Sudden onset weakness, facial involvement, or any accompanying neurological change or urgent symptoms. Same-day evaluation, not watchful waiting. Number 1. In most cases, multiple contributors are operating simultaneously, each reducing nerve reserve until ordinary nightly pressure overflows what remains. The solution is to reduce the total burden, not just the most visible piece of it. 3 things, that is all I am asking. First, write out your symptoms precisely and bring that description to your next appointment. Second, try nighttime wrist bracing for 2 weeks and note what changes. Third, ask for the complete panel: B12, MMA, homocysteine, full thyroid, glucose, HbA1c. 3 things, 2 weeks, then come back to the comments and tell me what you found. Your hands are not failing you. Your nervous system is sending requests in the only language it has for the specific support it needs. The signals at 3 in the morning are not noise. They are information, and now you know exactly what to do with it. You are not broken. Your nervous system is not broken. The information you were given was broken. Share this with one person who has been shaking their hands awake every morning without knowing why. Subscribe to this channel because every week I come here to close the distance between what the research shows and what you have actually been told. Aging does not take away your body's ability to recover. It simply reminds you to care for it the right way. Take care of yourself.